Good morning, good afternoon, and good evening. Welcome back. We are now in the third part of this lecture on Parkinson's disease. We've tackled the definition of Parkinson's, its pathophysiology, and the etiologies. Specifically, we explained the theory regarding oxidative stress. Now, let's get to the fun part. I'm done explaining physiology stuff. I want to explain the visible things that we can actually see. And here we are, clinical manifestations of Parkinson's disease. Well, technically, that's not really the fun part for the patients, but it's easier to understand because it can be seen visibly. You can observe it visibly. So here is just a list of the common symptoms. It's got tremors, bradykinesia, rigidity, postural instability, gait, speaking and swallowing. Okay, that's it for the presentation. Thanks for watching. I'm kidding. I'm kidding. I'm pulling your leg, aren't I? Okay, that was so awkward. I'm the only one watching this, so. Okay. Okay. Hopefully, you still pay attention. Pay attention to my cursor. Look at the cursor. Okay. I know your attention span is really short. Okay, what am I doing? Right. Common symptoms. Let's go over them one by one. Tremors. The big bad tremor. So, tremor is one of the most prominent symptoms of Parkinson's disease, but it's not the only symptom. Remember that. It is popular and it's most prevalent, but it's not the only symptoms, okay? Let's give attention to the others. But for now, I will be discussing tremors. So, usually in Parkinson's disease, the most common tremor is a resting tremor. And what do I mean by resting tremor? Um, Usually the tremors you see in movies and shows are like when a patient raises their arms or their hands. For example, in The Pit, the medical show, in season one, Doc Robbie asked Louis to bring his hands up, and you could notice that his hands were shaking a bit. So those were tremors, genital tremors, kinetic tremors. However, in Parkinson's disease, resting tremors are the more common ones because what usually happens here is if they're simply just laying their hand on a table or just resting, just laying down, sitting down, that's when the tremors appear. However, once they perform a movement, say, and let's say they stretch out their hand, the tremors disappear. That's why it's called resting tremors. These are tremors that occur at rest. And we also have the pill rolling tremor. So here you have an image that could visualize it. You can imagine, picking up a pill, and usually your thumb and your index finger usually come into contact with one another. In patients with Parkinson's disease, you could observe this. They are continuously, have coming into contact. Their thumb and their index finger are continuously coming into contact. So, one differential that I will be introducing, although I will be discussing this further later, is that essential tremors can and is often confused with the tremors in Parkinson's, but one simple explanation is that if essential tremors are characterized by kinetic tremors, meaning tremors while they move their body, while they move a certain part of their body, while Parkinson's disease are characterized by tremors that occur at rest. Okay, let's move on to the next. Bradykinesia. So bradykinesia simply is actually translated as slow movement. So these are slowed movements. And one reliable indicator for bradykinesia is repetitive tapping of fingers or feet. So um, when they're tapping their thumb against their index finger, or they're continuously moving their toes, like tapping it one upon each other, that's one indicator that this could be Parkinson's. And there is the term what we call decrementing or decrementing. So this is a phenomenon where the amplitude of the tapping experiences a decreased amplitude as performance continues. Since bradykinesia generally just refers to slowed movement, and patients with Parkinson's are usually present with tapping. If they present with bradykinesia, they could start with very strong taps once they begin the action, but then slowly but surely the taps would decrease in speed and amplitude, so it weakens as they continuously perform the action. Next, we also have this term, paucity of movement. So this just refers to a lack of fluidity in movement. So, for example, in a normal patient, you are able to move your arms in coordination because you don't have affectations of the brain, right? If you're gonna reach for something on the table, if you're gonna carry a bag, you're gonna walk. The movement is flowing easily. But in patients with PD, there is a lack of that fluidity. Usually, they also have decreased dexterity, so they have a very difficult time to write or to type or to do things that require precise finite movements. Next, we have rigidity. So here, rigidity just means rigid, a rigid muscle, an increased muscle tone. And a cardinal feature, which is similar to the prominent feature, is that it's a cogwheel rigidity. So this is similar. I mean, this connects to the lack of fluidity in movement. For example, a patient with Parkinson's would, instead of just stretching their arm out, they would first flex their shoulder, extend their elbow, extend their wrist. So it's like the movements are isolated to certain parts. It's not okay, one fluid movement. It's simply slow movement. So I flex my shoulder, extend my elbow, extend my wrist. So it's not continuous. And that's what we call a cogwheel because a cogwheel like spins and turns, right? But it turns stiffly. That's usually what occurs in Parkinson's disease. To test for rigidity, we could use Froment sign. Usually, this is used to detect ulnar nerve affectation. So what you would do is you would have a patient stretch their arm out and the wrist, and you would have them close their palm like this, and then put a paper in between the thumb and the other fingers. Then the examiner would pull this paper outward, but the patient has to prevent them from getting the paper. In normal patients, it just remains in this position. There's no movement. They can fight the taking of the paper. But in patients that have ulnar nerve affectation, what would happen is they would bend their finger. Why? Because in this movement, to maintain this position, you would have to have strength of the adductor pollicis, which is an adductor of the thumb. But if your adductor pollicis is weak, you would compensate by flexing your thumb, bending your thumb. And the adductor pollicis is innervated by the ulnar nerve. So if you can't maintain the strength of that, one reason could be that the nerve supply is affected. That's what we call the Froment sign. This could be used to test for rigidity, especially in the hands. If the rigidity is not as visible in early Parkinson's disease. So I will further connect this because in the next slide, see here, I'm gonna connect it here. So we have postural instability. Usually patients with PD have forward flexed posture, the gamer posture, but it's much worse for them because it's really stuck in that position. It's very hard to move. So we have a term called captocormia. You can see in the picture here, this man has his trunk bending forward and his head bending forward. So this is not because he has poor posture, but rather because of Parkinson's disease. He is physically unable to straighten his back. So when he lays down, look, it's still slightly flexed even if it's laid down because it's rigid. There's instability. So imagine trying to walk with this type of posture. You would have a really hard time, right? We also have striatal hand position. So you can see it here. Striatal hand position is described by slight ulnar deviation, meaning your hand would go medially. And there is flexion of the metacarpophalangeal joint, but extension of the interphalangeal joint. So you can see here, flexion of the metacarpophalangeal, but extension of the interphalangeal. And we also have what we call the Pisa syndrome. So it is similar to a forward flex posture, but there is lateral trunk flexion. So that's even harder to move in that position because you're not just stuck in one axis, but you're stuck in another axis too. So it's really difficult for these patients to perform their ADLs because their posture is very much affected. Next, we have gait. So again, since there's instability of the postures, there's rigidity, of course, gait is also affected. Dystonia just refers to a prolonged lengthened position of the muscles, so it's stiff and it's lengthened. In patients with Parkinson's disease, usually it's interesting to note that even if they have usually have a forward flexed posture, they are actually prone to falling backwards, which is what we call retropulsion. And what happens is when they try to fall backwards, since their weight is like towards the anterior portion of their body, so they will compensate by trying to put their energy into their lower limbs and try to accelerate their footsteps to try and balance themselves again because if you try to balance yourself, if your body is like this, it would be very hard. So they would compensate by fascination of gait. That's what we call. And this is what we refer to as loss of postural reflexes. So for example, you could test this. You could have the patient stand in front of you, and the examiner is behind the patient. They would try and pull the patient backwards, like as if trying to make them fall, but of course not too much strength because that could cause a lot of complications. And the patient should be able to maintain their balance, but if they aren't in this, that's a loss of postural reflexes. We also have freezing of gait, so it's very obvious. So freezing of gait just means sudden pausing in. So this could last from a few seconds to a few minutes. And we have kinesia paradoxica, sorry. So this just means like a sudden, if this, if bradykinesia refers to slowed movement, kinesia paradoxica refers to sudden movement. So for example, the patient is sitting and then they suddenly stand up. That's one. And we also have other signs, apraxia of eyelid opening, meaning it's slow to open, they have a hard time opening it, tip of the tongue phenomenon, they're trying to say something, but they can't quite remember it, or they can't tell it out loud. And we also have the Myerson sign. Oops, sorry about that. So here I have a video to present freezing and fascination of gait, so you can just see. So look at the patient. So that's fascination. See, it's acceleration of the movement. He's trying to compensate his postural equilibrium. And freezing would usually involve just like this. They just remain still and they can't move. So yes. Let's go to the last one. So we have speaking and swallowing. In speech, patients usually experience hypophonia, meaning softer tone when they speak. Aprosody, loss of intonation. Dysarthria, loss, difficulty in speaking. Tachypnea, meaning they have difficulty speaking. They would try and speak fast, like they would be rapping. Palilalia means repeating of words. So like, they would repeat certain words to try and, let's say they're talking about a cat. Okay, I saw this cat on the street, and then I saw this cat on the street, and then I saw like they would repeat themselves, or they would repeat a certain word. It's like a fixation. And for swallowing, there is in patients with PD, usually there's a lot of drooling because they have a diminished ability to spontaneously swallow. So if you combine that with rigidity, that would be very difficult, right, to swallow, and you're just drooling. So there would be excessive production of saliva and spontaneous swallowing. I mean, diminished spontaneous swallowing. So that's it for the common symptoms of Parkinson's disease. So this is again, it's fairly easy to understand because this is a lot easier than the pathophysiology and all that because these are visible and you can clearly see them. I guess tip for this is just memorize the terms because they have etymology. So I think that's it for this one. Um, goodbye. I guess I'll see you in the next part. Yip yo, yippee hi yo. Okay, I'm gonna. All right. Goodbye. Goodbye.